So our today's lecture is one of my favorite subjects, radiotherapy for head and neck cancer with a focus on oropharynx cancer. Our speakers are Dr. Michael Ґенцхаймер and Nicholas Noem. Dr. Ґенцхаймер is a clinical associate professor in radiation oncology, currently specializing in treating head and neck cancer. Fun fact about Michael, he has BA degree in physics from Harvard, and he is one of the most efficient people I know. He is an awesome teacher. He spent a lot of time teaching our Ukrainian observers here. He's also a great researcher with inquisitive mind. He built AI predictive model to predict survival outcomes for patients with metastatic cancer. But today he will be talking about radiotherapy for oropharynx cancer, the clinical aspects of it. And our second speaker is Nick Noem. He is a great dosimetrist here at Stanford, Palo Alto. He was also our first medical dosimetry student as part of affiliation program with MD Anderson. We were so happy with him, and he was so excellent that we hired him. And now he is jack of all trades, planning virtually everything in the department, maybe except for CyberKnife plans, but he dabbles in everything. He has a great presentation on the planning for head and neck cancers. But first we'll start with the clinical part by the talk by Dr. Ґенцхаймер. So I'll stop sharing, Michael. Let's start sharing.
Sounds good. All righty. Well, this is great. It's great to see this nice turnout. So yeah, I'll talk for, I don't know, maybe 35, hopefully minutes or so, and then I'll stop for if there are any questions or discussion. Though feel free to ask questions along the way also. And then we'll do the next part. Okay, let's see. There's an AI assistant in the chat. Cool. Okay, fine. Yeah, any AI assistants are welcome. Alrighty, so yeah, so thanks so much. So Michael Shang made many of these slides that I'll be presenting several years ago for a similar lecture. And so thanks to him for letting me use those and modify those. I have some disclosures here. Okay, so we'll talk about clinical background of oropharynx cancer, treatment approaches, and some details of radiotherapy considerations. And then Nick will tell us about the some of the details of the simulation, treatment planning process, and IMRT optimization and all that. I left this picture in from Michael's version of the talk. I don't know why there would be a sign that has roadmap on it. Maybe someone can figure that out, but okay, anyway. Alrighty, so our first discussion question for the audience. We have a 55-year-old non-smoker who presents with a 3-centimeter painless upper neck mass that you can see here. Biopsy of the mass shows squamous cell carcinoma. What is the most likely primary site for this cancer to be? So where did the cancer start? And you can see the 5 options there. Oh, I get to answer also. Okay, I'm going to answer. All right, so we've got the poll results. So we have larynx, oral cavity, nasopharynx, but most people said oropharynx, including me. So yeah, that's correct. So this cancer most likely started in the oropharynx, especially for a non-smoker who's younger, like this patient. That would be the most likely primary site for this upper neck mass. In somebody who's very elderly, like maybe 90 years old or something like that, maybe skin would be quite likely as well. Alrighty, so let's talk about epidemiology and risk factors. Head and neck cancer is a relatively uncommon cancer type. It's 3% of malignancies in the United States. About 30% of these are oropharynx cancer. The rate of oropharynx cancer has been increasing over time. You can see some graphs here on the right showing men 45 and older with a pretty steady increase in oropharynx cancer incidence. And the reason for this increase is because of the HPV virus, human papillomavirus, which is really triggering this epidemic in oropharynx cancers. These cancers are male predominant. Tobacco and alcohol use are risk factors for it. And the vast majority of cancers in the oropharynx are squamous cell carcinomas. We'll come back to the HPV stuff in a later slide. In terms of anatomy, probably very relevant to this audience. So the oropharynx is shown in green on the right. So it's the middle part of the throat. Above it is the nasopharynx, which is behind the nasal cavity, and below it is the hypopharynx and larynx. And in front of it is the oral cavity. This lists the precise borders of the oropharynx, which I won't go into all the details on that, but you can see them there. The tongue is a little confusing. The front 2/3 of the tongue are considered part of the oral cavity. Cancers in that area tend to happen in people who smoke cigarettes, drink alcohol, maybe chew tobacco. Those are risk factors for oral tongue squamous cell carcinomas. The back, approximately 1/3 of the tongue, is the base of the tongue, and that is part of the oropharynx. So there are these bumps on the tongue called the circumvallate papilla that divide the oral tongue and the base of tongue. In terms of subsites of the oropharynx, here are 4 listed here. Tonsillar fossa, where the tonsils live, the back of the tongue, base of tongue, soft palate and uvula. The uvula is the thing that dangles down in the back of the throat, and the oropharyngeal walls. Here is a view of the oropharynx. So let's see. So we can see the base of the tongue, the back part of the tongue. Here's a tonsil inside the tonsillar fossa. So we have the anterior tonsillar pillar here, the posterior tonsillar pillar here, and the tonsillar tissue is nestled in between those. Let's see. And then we have the uvula, soft palate. These are also parts of the oropharynx. This is the posterior pharyngeal wall back here. So it's basically a straight back looking into the mouth. That's part of the oropharynx also. Yes, oropharynx, there it is. So oropharynx cancers love to spread to lymph nodes. And so you definitely need to know about where they like to drain to. I put in this is one of the biggest papers looking at neck dissections for oropharynx squamous cell carcinomas. So they did neck dissections on 213 patients with this cancer type, and then counted up what percentage of the patients had cancer in the lymph nodes on pathology and which lymph node levels were involved. 77% of the patients had clinical nodal involvement. So that means there was generally a lymph node that could be felt or that showed up on the CT scan as enlarged even before the neck dissection. And 72% of the patients had a positive lymph node found on pathology. So very high rate compared to some other cancer types. The most commonly involved neck nodal levels in that study were level 2, 3, 4, 1, and 5 in that order. Level 2 is almost always involved if there are any lymph nodes involved. And this diagram shows those nodal levels. So 2, 3, and 4 are the lymph nodes that go along the internal jugular vein. I don't know if you can see, this is the internal jugular vein going all the way up and down through the neck. They're kind of showing it behind the sternocleidomastoid muscle, which is coming across here. Anyway, those are lymph nodes that live around that vein. Excuse me. Level 5 is the posterior triangle nodes behind there, and level 1 is in front. Yeah, level 2. Anybody the dosimetrists know this well. The oropharynx cancer patients, we're almost always including a lymph node that's involved in this level 2 upper neck area. Also, everyone, please stop me at any time if you have questions about any of this. Clinical presentation. So patients often present with an enlarging neck mass. Sometimes the tumor in the throat can cause pain with swallowing or food getting stuck in the throat. Patients often have ear pain, which is from referred altalgia. So this means that there are nerves that part of the nerve branches off into the throat or the tongue. Part of the nerve goes into the ear. And so you actually have pain in the throat, but you feel it in the ear. Very, very common. In terms of workup that should be done, the patient should have a scope exam, basic laboratory tests. Excuse me. This says exam under anesthesia. I would say we generally don't do this anymore. Now that we have PET scans and really nice fiber optic scope exams, we don't usually need to put the patient to sleep to see where the tumor is. The patient should have biopsy of either the primary tumor or a neck node. For any oropharynx cancer, they should have testing for HPV virus in the specimen to see if it's an HPV-associated cancer. You could either do this directly by looking for HPV DNA, or you can do immunohistochemistry staining for P16, which is strongly correlated with HPV. So if P16 is positive, the tumor is probably HPV positive and came from HPV infection. And we want to know about that because that can, the HPV status can affect mostly the prognosis. So the HPV negative tumors are much more aggressive and come back a lot more after treatment. You'll want to get some imaging with a CT or MRI and a PET scan. For referrals, you need dental and speech-language pathology referrals. The radiation can reduce the blood supply to the teeth, and so any bad-looking teeth need to be pulled before radiation because it can be dangerous to pull them after treatment due to that decreased blood supply. Radiation can also cause problem swallowing from scar tissue in the swallowing muscles, like the pharyngeal constrictor muscles. And so we refer the patients to see the speech-language pathology team, who will help them with supportive care, like swallowing strategies, some exercises to do swallowing and jaw opening exercises. Here we also submit dietitian referrals because patients often lose a lot of weight during treatment, and they can help guide them in terms of nutritional shakes and things like this to do. And if the patient might be getting chemo, we get a hearing test. All right, here's the scope exam. So we do a lot of these in our clinic. So it's this flexible scope with fiber optic channels in it, so you can, there's a camera. The fiber optic channels carry the light, and there's a camera typically at the end of the scope, and it lets us see very nicely into the throat, goes through the nose, a little bit uncomfortable for the patient. Sorry to all the patients I've done scope exams on, and it goes down into the throat. You can see this area nicely. This is the view. So this is the front, back, right, left. This is showing you the epiglottis. That's sort of the top part of the larynx. And you can see the base of tongue through here. I think some things will be labeled here. Yeah, so there's some folds. This is the median pharyngoepiglottic fold here, lateral pharyngoepiglottic fold. That's probably not so relevant for the dosimetrists and physicists in the audience, but it would be more relevant for the physicians. These are the piriform sinuses, so this kind of depression on either side of the larynx. Okay, so the base of tongue would be through here, as we discussed. That's part of the oropharynx. There's the larynx underneath. Some examples of masses. So here is a mass in the left base of tongue. This was squamous cell carcinoma. There's the mass. This one's pretty obvious. So this one's in kind of midline base of tongue through here. Again, the base of tongue is in front of the epiglottis. So, yeah. This patient has a mass in the right tonsil. So here's the posterior tonsillar pillar here, and I guess anterior pillar is a little hard to see, but it'd be through here. And then you can see in the right tonsil, there's this hypervascular mass. Do you see those dilated big blood vessels on there? So that tends to happen when you have a cancerous mass in the tonsil. Yes, there it is. Some imaging. So MRI, CT, and PET all usually show these tumors very well. But here is a left tonsil squamous cell carcinoma. Do you see on this side? It looks almost like a mass on this side also, right? That's just the normal tonsil, which tends to have this kind of rounded appearance. This is probably a younger patient. In older people, the tonsillars get more atrophied. But anyway, here's the tonsil mass. Here on the PET scan, it takes up, or anyway, it's quite FDG avid, so it takes up lots of FDG. And then they have an involved lymph node here on the PET scan. Don't be fooled. There's some brightness in the tonsil on the other side. That's not from cancer. That's just what we call physiologic uptake, because there is a lot of lymphoid tissue in the tonsils, and they tend to be bright. Same with the base of tongue. All right, here is a lymph node involved from a base of tongue cancer. HPV positive oropharynx cancers often have cystic nodes involved. So this means there's a lot of fluid in the middle of it. You can see this is a CT scan. So the fluid is dark. This is a contrast enhanced CT. So the area of the active cancer on the edge of the lymph node is bright, and then the dead cancer cells in the middle are dark because they're necrotic. That's very characteristic of HPV-associated oropharynx cancer. And there's the base of tongue mass also as a bonus. Alrighty, HPV virus. So HPV is transmitted by physical and sexual contact. For oropharynx cancer, this would generally be oral sex, I think, is definitely a big risk factor for oropharyngeal HPV positivity. Most people clear the infection, so pretty much everybody gets exposed to HPV during sexual contact, or kissing, oral sex, these sorts of things. And for some reason, in certain people, it kind of persists and then can cause these cancers. Oh, the AI assistant is still talking to me. Okay, hi, I'm still here. Let's see. Yeah, and men tend to have a higher HPV prevalence in the throat than women. I don't think that's fully understood why that is, actually. It might partially have to do with the increased smoking and drinking among men. But yeah, HPV causes a large percentage of oropharynx cancer now in the United States. So here's an example at the bottom right. Sorry, my light's going to turn off, so I'm going to wave my hands here. So the dotted line is non-HPV positive head and neck cancers, and you can see that was pretty constant over time. I believe this was in Stockholm, Sweden. And then the shaded line is the HPV positive ones, and you can see that just really skyrocketing. Let's see. Okay, some key differences between HPV positive and negative oropharynx cancer. HPV positive is increasing in incidence. HPV negative is decreasing as people have fewer unhealthy habits. You can look at the risk factors here. The HPV positive ones probably have a slightly higher risk of distant metastases compared to the HPV negative tumors, but this is a little bit overstated. I mean, they can also have many of the recurrences are also in the radiation field in the HPV positive tumors. And the cure rate for the HPV positive ones is much better. Here is a graph from the RTOG 0129 trial. So they looked at the survival rate of the patients who had HPV positive or negative cancers in that trial. This was radiation plus chemo. And you can see how much better the survival chances are when you're HPV positive. It's pretty striking. This is this famous kind of decision tree kind of thing, sorting patients into 3 different risk groups based on the results of the secondary analysis of that trial. And so here are the groups on the right. So basically, if you're HPV positive and you have a small smoking history or a larger smoking history and not very much nodal disease, you have a really excellent survival rate of 93%. And that the greater the smoking, the more advanced or bigger the cancer, the lower the survival chances. I'm going to go pretty quickly through the staging because we're going to get bogged down in this. But the general idea here is that in the current version of the American Joint Commission on Cancer staging system, HPV positive and HPV negative oropharynx cancers have different staging. For those who don't know, the staging helps us indicate how large the cancer is, how far it's spread, and the cure rate of treatment. So we have a T stage for the tumor, how extensive the primary tumor is, and an N stage for nodes in terms of how extensive the nodes are. So the thing that's confusing is that for the HPV positive tumors, because the cure rate is so high, they decided to lump a lot of those into stage 1 to indicate that they would have a good cure rate. So some tumors that used to be stage 4 are now stage 1, which is a little confusing. The key thing here is that you still want to treat them exactly the same as we always treated them. Just because the stage changed doesn't mean that we should not give chemo or something like that to them. And most of the clinical trials use HACC 7th edition staging. So we kind of treat the patients according to the old staging system, where some of the tumors are stage 1 through 4, but we also report the HACC 8th edition staging, where a lot of these tumors are stage 1 now. This kind of indicates that. So you can see that, for instance, this is for HPV positive tumors, like for N1 here. So you can have multiple lymph nodes on the same side as the primary tumor. As long as they're all less than 6 centimeters, it's still N1. Whereas in the past, that could be N2 or that could be N2. The stage 1 tumors like a T2N1 would be stage 1, even if they have a bunch of lymph nodes involved, which is a big change from previously. Here's the HPV negative staging, which is much more similar to the prior additions, though you can see extracapsular extension of the lymph nodes has been added in the current AJCC edition. One note about the extracapsular extension, we only call it extracapsular extension for the clinical stage if it's present on physical exam or it's extremely obvious on the imaging. If there's subtle extracapsular extension on the imaging, you can't call it ECE because the imaging is not very accurate for that. Okay, treatment approaches. So for early stage cancers, we start with either radiation or surgery. This would be a T1 through 2 tumor with up to one node less than 3 centimeters. So AJCC 7th edition N1. If they start with resection of the tumor, then we give post-op radiation. If they have the high risk features listed here, such as T3 to T4 stage. If they have surgery and they have extracapsular extension or a positive margin, then we add concurrent chemotherapy to the radiation. This is based on the results of the Bernier meta-analysis of the EURTC and RTOG trials. For locally advanced oropharynx cancers, so typically T3 to T4, or they have bigger nodes, we typically will give those patients radiation combined with chemotherapy instead of surgery because it's very difficult to safely cut out all the cancer with surgery. And the general goal of the treatment is to maximize the cure rate while reducing the intensity of the treatment. So for instance, doing surgery plus radiation and chemo is generally quite tough on the patients and leaves them with a lot of long-term problems. And so we try to avoid that if possible. All right, in terms of results for radiation alone for early stage disease, probably one of the best studies on this was the RTOG 0022 trial. This was a single arm trial where they did IMRT radiation for patients with early stage oropharynx cancer. They did 66 gray in 30 fractions. So the dosimetrists on the call will sometimes see us doing this for early stage oropharynx patients that are getting radiation alone. And they saw great outcomes. So the local regional failure rate is here over time, 0 to 5 years after treatment. And you can see it is quite low. 2-year local recurrence risk was 9%. And the overall survival was also excellent. So yeah, we were really happy to see these results of the study. I wasn't involved in the study, but I think the field was very excited to see these good results. Yeah, in patients with major dose deviations, there were some of them, they seem to have a higher risk of local recurrence, which is not shocking. And most of all the recurrences were in patients who had smoked, none in never smokers. They note that they did not do HPV testing in this trial. So probably these former smokers were HPV negative tumors that are more aggressive, and that's probably why they had recurrences. But this helps set a baseline for results from radiation alone for early stage disease. Okay, role of surgery for early stage disease. So historically, surgery was very hard to do for oropharynx cancers, for larger ones, because you'd have to split the mandible bone and kind of open up the patient's face, which you can imagine is not very fun. And so that helped lead to the use of radiation for these tumors. But now we have the robot. So this is the surgical console for the Da Vinci TORS transoral robotic surgery robot. I mean, it does more than just TORS. They can do other disease sites too. But the surgeon just sits at this special console. They have 3D vision of the operative area. They have these extra fancy hand manipulator things so they can control the robot, which is shown here with the various different robot arms in the patient's mouth. And so now you can do the surgery for the tongue or tonsil tumor through the mouth, and the robot can bend the arms to get down the throat and all this, and you don't need to open their mandible anymore, which is really exciting. I would say we're still figuring out which patients benefit more from the robotic surgery compared to radiation. It's an area of controversy for sure. Some surgeons are very aggressive and operate on a lot of the patients. Some surgeons are much more conservative and will only operate on somebody with a very small tumor. In terms of data on radiation versus surgery, there is not a lot. Probably the most famous studies were the Orator randomized studies from Canada, from David Palma and Anthony Nichols and their colleagues. So they randomized patients with early stage oropharynx squamous cell carcinoma to radiation or surgery to begin with. Some of the radiation patients got concurrent chemotherapy, and the patients who got surgery basically they looked at the results on pathology and gave them adjuvant radiation or chemoradiation if needed. And the primary endpoint was swallowing function at 1 year. And here are the 1 year results. So you can see in the radiation arm, the 1 year swallowing function was better than in the surgery arm. Though, you know, on other time points, they're looking pretty darn similar, but that was the primary endpoint, and that was better in the radiation arm. Most of the patients who got surgery needed to get radiation afterwards, 24 out of 34. You know, one thing that was very concerning was that they saw 4 serious bleeds in the surgery arm, and 1 patient actually died from this, which is, you know, obviously really concerning because these are patients who generally would have a very good prognosis. And so overall, I'd say the results of this trial supported probably more use of radiation rather than surgery. They did a follow-up trial, so very similar, which also had 2 early postoperative deaths. So yeah, that the surgeons here, I would say, would say that in their hands, the risk of bleeding and serious complications are quite low from transoral robotic surgery. And I think that's probably correct based on my anecdotal experience working here and seeing a lot of the robotic surgery patients. Other studies have also shown a lower bleeding rate. So it's an area of controversy. It's a tricky thing doing these robotic surgeries, I think, and there's definitely a learning curve. And so the results are going to depend a lot on who's doing it and how much experience they have. A lot like head and neck radiation. So. Okay, I'm going to speed through this part a little bit, but for patients with larger tumors or a lot of lymph node involvement, they have improved survival with the addition of chemotherapy. This is the GORTEC, this very famous GORTEC study that helped establish this overall survival benefit. One note is that they use carboplatin and 5-fluorouracil chemo. This was done in France, and I think they still tend to do that there. They saw increased acute toxicity with more mucositis with chemo, but similar late toxicity. And then in the United States, based on other trials and just historical practice, we tend to use cisplatin along with the radiation instead of carboplatin 5-FU. And then this meta-analysis also just sort of cemented the evidence for the benefit from concurrent chemotherapy for the patients with bigger tumors, with about a 5% 5-year overall survival benefit to adding the chemo. All right, so a hot topic is de-escalation of treatment. So the idea here is we know that HPV positive oropharynx cancers have a really excellent cure rate with chemoradiation, but we know that the treatment can leave people with chronic issues, hearing loss, kidney damage, swallowing problems, dry mouth, taste changes, risk of stroke, secondary malignancy, all these things. So could we try to reduce these side effects and maintain the excellent cure rate? And there have been various trials looking at this. We have active trials here looking at this, such as the NRG-HN005 trial. So far, I'd say the big trials have been kind of disappointing. So this is one of the more well-known ones that our chair, Dr. Lay, was highly involved in, R2G1016. So they were trying to substitute cetuximab systemic therapy instead of cisplatin chemotherapy, along with radiation, for patients with HPV positive oropharynx cancer. So they randomized to those 2 different drugs. Cetuximab is a targeted therapy, which as in the past was thought to have fewer side effects than cisplatin. So that was the hope that we could reduce the side effects. Unfortunately, did not work out. So the cisplatin kind of old style chemo turned out to have better overall survival and local failure rate, as you can see here on the right. Also, really disappointingly, the patients really did not have less toxicity with the cetuximab. So I believe the rate of feeding tube use was about the same in the 2 arms, and the rate of severe toxicity was the same in the 2 arms. So it was kind of a dud in lots of different ways, but yeah, definitely did not show equivalence of the cetuximab to the cisplatin. And so we still, to this day, use cisplatin along with radiation for these patients. Another way you could de-escalate the treatment would be, oops, sorry. Okay, I'll close MIM. I hope I saved my session. Sorry, let me just log in so it goes away. Would be to reduce the radiation dose. So there's a lot of excitement about this. So we could potentially reduce the radiation dose from 70 gray to 60 gray. There have been some smaller trials looking at this. So my apologies about this. There have been some smaller trials looking at this. So the NRG-HN002 trial looked at 2 different experimental approaches. There was no standard of care arm in this study. So 60 gray radiation alone, or which I believe was accelerated, so 6 fractions a week, or 60 gray plus weekly cisplatin. And they did see an increased risk of local recurrence in the radiation alone arm. You can see it here. Not a super high risk, but definitely a higher risk than the arm that got chemo. So the 60 gray plus chemo arm looked better and was chosen to proceed into a phase 3 trial. So the NRG-HN005 trial is an active phase 3 trial looking at some 60 gray arms here. You can see the 3 arms listed here. So this is a big trial, many hundreds of patients, which will help to definitively answer whether reduced dose of radiation of 60 gray is acceptable for this HPV positive oropharynx cancer. Now, unfortunately, one of the de-escalation arms has been closed for futility. So I got this scary looking email saying temporary closure of the protocol because we were putting patients on this trial. And they did an interim analysis and found that apparently the 60 gray plus cisplatin arm was not looking good enough and to have a good chance of showing superiority if they had continued the trial, superiority to the current standard of 70 gray. So they dropped that arm and they're continuing with only the 60 gray plus nivolumab versus the standard treatment. So yeah, people found this pretty interesting, and I think it just reinforces that even if something seems theoretically very attractive to like reducing the radiation dose, and we think it's going to have a good cure rate, we really need to test this in big trials against the standard treatment. So in my opinion, generally radiation dose de-escalation should only be done on trial for these tumors. I guess the only asterisk is that there was a ECOG trial that looked at TOR surgery followed by either 50 or 60 gray of radiation, and they saw equivalent results in the 50 and 60 gray arms. It wasn't that many patients as a phase 2 trial, so it's not definitive evidence, but it is pretty exciting, I think. And so I don't think it's crazy to give people 50 gray post-op for some of these selected patients, though typically here we've stuck with 60 gray for post-op treatment. All right, radiation considerations. I'll skip through a little bit of this. Quality of the treatment is really important. If people are interested in that study, they can look at that later. We know that intensity modulated radiation therapy is helpful for patients with head and neck cancer. So the landmark study that showed this was the PARSPORT trial in the United Kingdom, where they randomized them to 3D conformal or IMRT radiation. IMRT, they did contralateral parotid sparing, and they saw improved dry mouth in the IMRT arm. Note that this trial was published in 2011, so this is kind of older style IMRT, and they weren't trying to spare as many things. So here we also spare things like pharyngeal constrictor muscles, and there was a more recent trial showing that sparing those muscles improves swallowing function. So yeah, I mean, IMRT is definitely extremely helpful for these patients in a lot of different ways. Okay, dosing guidelines. So head and neck contouring and dosing is complicated. I don't really think I have time to fully go through all of it here, so I'm going to go through kind of quickly. And if people have other questions for me, I have some guideline document I'm happy to email to people or discuss it with them. But for definitive treatment, we do 70 gray in 33 fractions to the gross disease. The CTV margin that Dr. Lay and I use is 3 millimeters for this volume from the GTV. High risk subclinical disease gets 56 gray. So that would be the primary tumor plus 1 centimeter, and then any lymph node levels that are involved with the cancer. And then we do elective nodal coverage. Remember, these oropharynx cancers have that 70+% nodal involvement rate. So you really need to cover those lymph nodes for any oropharynx patients. And so the elective areas like the contralateral neck, the low neck, that can get 52 gray simultaneous integrated boost in the same 33 fractions. Okay, we have the RTG0022 dosing for radiation alone, kind of very similar to the definitive radiation dosing, or definitive chemoradiation dosing. Sorry, CRT means chemoradiation therapy. For post-op radiation, we treat to 60 gray in 30 fractions generally. We'll treat the operative bed. and a margin on the preoperative tumor to 60 gray. So I always fuse in the preoperative imaging. You can consider boosting positive, well, if there's a positive margin, I would definitely boost that to 66. And if there's extracapsular extension, some physicians will boost that to 66. Dr. Lay and I, if the patient's getting concurrent chemo, we typically do not boost the area of ECE to 66 because the chemo helps make the radiation more intense against the cancer. But that is something that many people will do. Lower risk areas get lower dose, as you can see here. Our PTV margin is 3 millimeters, typically. If you're going to do that, you have to have really, really careful alignment and everything, right? So you're going to have to carefully check your daily films. If the patient seems to be misaligned, you're going to have to do something about it. So try to figure out how to reposition them or resim, because that's quite a small PTV margin for head and neck. With these pesky clavicles, neck, chin, everything, there's so many degrees of freedom that it's just really hard to get everything nicely lined up. Oh, just a little side note on HPV positive tumors elective dose levels. So there was this exciting trial that came, or not trial, sorry, exciting study came out a year or two ago from Sloan Kettering. Oh, Jillian was one of my med school classmates, so that was exciting to see her publishing this. But yeah, they did a 30 gray elective neck dose for HPV positive oropharynx patients who were getting radiation plus chemo, 30 and 15. So that's a very low dose compared to what we've traditionally given. And they did this with 276 patients, and they only saw one nodal failure in the 30 gray volume, and with a median follow-up of, I think, 28 months. So decent, not amazing follow-up, but decent time. So that was really exciting. I'll note that this was retrospective. This was not a clinical trial that they did. So, you know, there could be some selective reporting or this sort of thing, but no, very exciting results. Partially based on this and from other studies, Dr. Lay and I have started doing 40 gray and 20 fractions for our elective nodes for HPV positive oropharynx patients who are getting radiation plus cisplatin. So we've been doing that for, I don't know, about a year, and it's been going fine. It's a little bit of a dose de-escalation compared to our traditional dosing. Honestly, it's not even that big of a de-escalation. It's just kind of a modest one. But the reason, so we're doing a sequential boost now to the gross disease. The reason why we do sequential boost in this situation is that the elective nodal dose per fraction is getting extremely low. So if you did that in 33 fractions, it's a tiny dose per fraction, and there'd be concerns about accelerated repopulation, the cancer kind of outgrowing the radiation effects if you do too low of a dose per fraction for these rapidly proliferating head and neck cancer cells. So that's why we're doing sequential boost for these patients. We're not quite ready to go to 30 gray, I think. I think we'll do this for a while and see how that goes. Okay, nodal coverage areas. Okay, sometimes we can treat ipsilateral neck. For oropharynx, that would typically be for early stage tonsil tumors, where we can avoid the contralateral neck coverage. So here are the criteria. If they're T1 through 2 and node 0 to 1, so up to one node that's less than 3 centimeters, with less than 1 centimeter of soft palate or base of tongue involvement, then you can treat the ipsilateral neck. If the soft palate or base of tongue are more involved, or if the tumor started in there, you got to treat the contralateral neck because those are more midline structures and they love to drain to the other side. I'm being a little conservative here. Some people, let's say there's a node that's 4 centimeters. Yeah, I think N2A, I'd probably treat ipsilateral too. So I'll change that in the slide later. So I think N2A, generally, we would treat ipsilateral as well. For N2B, that would mean multiple nodes. I always treat the other side of the neck, though some other people might still treat ipsilateral. This shows you the nodal levels to include. So we always include 1, 2 through 4 in the lateral retropharyngeal nodes. 1B if level 2 is involved with, or if there's oral cavity extension. We treat the retrostyloid nodes if level 2 is involved on that side. And then on the node positive neck, we treat level 5, which is the posterior triangle nodes. I'm going through it kind of fast. Sorry for speeding through it, but there's just a lot of things to get through. I'm actually mostly, well, I have a few more things, so I'll just keep going. Here are some example volumes. So there's a base of tongue tumor and bilateral neck nodes. So here up on the left side of the screen here, this is from the MD Anderson handbook that Dr. Beadle helped to write. I was one of the authors of. So here we have some retropharyngeal nodal coverage. They're doing bilateral because it was a base of tongue tumor at midline. They're doing that high level 2 coverage on either side. And then as we get down lower, here's gross tumor circled in green. And they have a 70 gray CTV or PTV here in red. And then a lower dose, it's probably a 63 gray PTV that they have in blue. And the traditional MD Anderson elective or doses are higher than the ones we use here. So their 63 gray would be our 56 probably. But they're doing, you can see they're doing elective coverage of bilateral 1B nodes here because of the level 2 involvement. They're also electively covering level 5 bilaterally. That's the nodes that live behind the sternocleidomastoid muscle, so posterior to that. Yeah, pretty much the same thing here. You can see at the primary tumor site, they're covering a generous amount of the base of tongue kind of around there with the lower dose level. And then as we get into the low neck, they've switched to a lower dose level in this side of the neck because there were no lymph nodes close to there on that side. On this side of the neck, there were low neck nodes present, and so they're staying at that intermediate dose elective volume for this part of the neck. There's the whole thing put together. You can see on this side of the neck, no low neck nodes, so they're going to a lower dose at the lower part of the neck there. Oh, our next question. All right, let's get our poll going. Which toxicity causes the most hospitalizations during radiation to the oropharynx? We're moving into the supportive care section for the last few minutes here. Oh, I'm going to answer. Oh, you guys are too good. I don't know why am I even doing this lecture? You know everything already. Come on. Okay. Yes, so mucositis is the winner. I saw some people said lymphopenia also. Yeah, so like decreased blood counts definitely cause some hospitalizations during the radiation, but that would more often be from neutropenia from the chemotherapy, the decreased neutrophils, rather than decreased lymphocyte counts from the radiation. So yeah, mucositis, exactly. So you treat 70 gray, like if I go back to this here, like you treat 70 gray to this big of an area in the throat, the patient is going to have a very bad, yeah, here on the sagittal view, going to have a very bad time. So they're going to get horrible mucositis all through the throat and mouth, a lot of mucus in there, pain. They won't be able to eat pretty much any solid foods. They'll be on liquid foods toward the end of the treatment. With this amount of dose, actually, this patient probably would require a G-tube for nutrition if I had to guess. If they don't put it in before treatment, they'd probably need to put it in afterwards, or I'm sorry, sometime in the middle of the treatment because they just couldn't get enough nutrition and fluids in. Yeah, so in terms of acute toxicities, we talked about the mucositis. They can also get these other things shown here with dermatitis, fatigue, dry mouth, taste changes, difficulty swallowing, and hair loss, especially people lose a strip of hair across the back. And then men would lose beard and beard hair as well. These are some supportive care things that we do during treatment. So the supportive care, a lot of it is not really evidence-based. Like we don't really have good data for the use of things like moisturizers and salt and baking soda rinses, but yet we do them and they do seem to help. So we'll have the patients use skin moisturizers. We do mouth rinses with salt and baking soda. Again, if anybody wants the recipe for any of this stuff or some of the guidelines that we use here, just have Natalia send me an email or send me an email afterwards. And I'm again happy to share any materials that we use. Let's see, we start the patients on gabapentin from day one, actually. So we have this escalation schedule where they start on a low dose and then gradually ramp up. And that really seems to help them get through without a feeding tube generally. They're commonly needing to take narcotics at the end of treatment though, like oxycodone. Let's see. Yeah, thrush is very common. So people often get a fungal thrush infection toward the end of treatment or afterwards. So I treat that with fluconazole. Late effects. Yeah, maybe I won't go through everything. I mean, they're all listed here. These are probably the most important ones. There are other things too, but this is some of the important ones. All right, and then this is my last slide. So just finishing with future directions. So I think in terms of where things are going to go in the next 10, 15 years, we'll get the results from some of these trials of doing de-escalated treatment for HPV positive patients. So for post-op, there is a big trial called Pathos that's active, headquartered in the United Kingdom, which will help us answer this 50 gray, whether we can reduce the dose to 50 gray. For definitive, we talked about NRG-HN005. I'm hoping that we have more personalization. It's a little bit one size fits all right now with these treatments. So I'd love if we could figure out how to personalize the treatment more. So for instance, if a tumor is shrinking really quickly during treatment, does that indicate that it's more treatment sensitive and we can stop at a lower dose? Using mid-treatment imaging, this sort of thing, and blood biomarkers to tell how much of the cancer has been killed already, like circulating tumor DNA. I think there'll be a lot more of that in 10 or 15 years. How to incorporate immunotherapy. So that's, there's a lot of excitement with anti-PD-1 immunotherapy like pembrolizumab for head and neck cancer, but the trials in localized disease have been negative so far. And then the role of protons, other radiation technology. There's some active randomized trials of protons versus X-rays. We're hoping to get protons here pretty soon, so that'll all be very interesting to figure out how we can best use that resource. That is my slides. Are there any questions for me before we move on to next part?
Yeah, we'll open the floor for questions for Michael.
Or comments. If I got something wrong, tell me that too.
Yeah, that was an excellent talk. Thank you, Michael.
Well, thank you. Thanks so much. Thanks everyone for attending.
You have to run to the clinic, right?